why do you think it's confusing? What's confusing about it?
Well, because if I choose the current, so if I place the implant 3 millimeters from the current level of adjacent free gingival margin of the adjacent teeth, well, that's fine. But then what about if I need to do a graft on the adjacent teeth in the future? That's one question. And also looking, I mean, it looks like it does need a graft looking at the tooth next to it, number 24, because when I do my flap, is it going to recede even more? Now my implant placement where I wanted it to position it is going to be off, right? So just by doing the implants, that free gingival margin is going to move. And then if I'm going to do a soft tissue graft, now it's going to move again, and it's not going to be in a predictable position. So it's not so important because this is not in the smile line, but because I'm new and because I want to get this right, I want to really think about it.
Beautiful.
And the other thing is, well, we are going to do a free gingival graft or a connective tissue graft. Which one do you do first? And I'm also restricted because I don't want to leave the implant for too much longer and lose too much more bone. 4 to 6 weeks to get that connective tissue, that's good, but I don't want to wait another 2 months, 3 months or whatever.
So Vash, first of all, everything that you said resonates. These are true thoughts and true considerations when it comes to placing implants. The depth of placement, the ideal gingival margin, the adjacent teeth, the quality of the tissue, the quality of the bone, all of these are, factored in. What we need to think about is what's realistic too. What's realistic within the circumstances, and because most of us here in the program are, beginner to intermediate, we don't always know, do we need to get every case to ideal? Is it expected from us? Is it something that, we will be scrutinized against if we don't do it? So I welcome all these questions or points. The bottom line is I start with, I have like a priority list. And the priority, first of all, let's see if we have room for an implant. It's a bit premature to tell. Why is that? Very commonly, for a single incisor, whether it's a lateral or central, they're basically the same anatomy. We always struggle for space. It's very, very rare to have a lot of bone, mesiodistally and buccolingually, period. So that's like in the priority, that's like, do I even have space to do it? Let's find out. Okay, so your suggestion to go back and 4 to 6 weeks later, check for bone, great. Okay, I can tell you now that the roots, at least from the X-ray, are very close. They're almost they have almost like root proximity. It could be just the angle of the X-ray, but it's very common. Second, you have already some.
It felt like I could fit a 3 millimeter in there, but I didn't really measure.
Doubt that. I don't doubt that. Yeah. But I think that's, hopefully you agree, that's still something we're going to establish. By the way, when I talk to my patients, I undersell, for these situations, I undersell the implant part. I undersell it because I tell them, listen, now we're removing the tooth that is broken and infected, whatever the reason may be. We're going to graft, and we're going to revisit it in 2 months. And then we'll run a simulation with a CT scan, with an optical scan, all the diagnostics. So that's the first thing that I'd like you to consider. Before we talk about gingival margin, how to treat the adjacent teeth, is it even an implant candidate? If it's not, it doesn't mean the patient will be edentulous. They'll probably have some type of bonded restoration. Second, when we talk about soft tissue, when you see the recession, your point of having thin tissue is correct. Very thin tissue, but I wouldn't call it no keratinized tissue, no attached tissue. There is some to work with, and that's good. And there's a little Freenham pull there, but there's some to work with. So I don't think they need a free gingival graft, at least not the way I see it now. And lastly, if we wanted to pull the tissue to cover the roots, well, hold on. Yeah, technically we can do it. However, we have some interproximal bone loss. That's going to limit how much we can pull. So I'd like you to be like, okay, we call it a second level thinker. I'm not saying you're not, but it's called a second level thinker. You're already a second level thinker, but I want you to be like a third level thinker. Like, let's dig another level deeper than that. Is there bone? Yes or no? Is there space? Yes or no? Is the tissue adequate? Where should I place the implant? That's the second level. The third level, okay, we want tissue, but can we even achieve that? So I think a lot of these answers will come to us when I see and you see a healed ridge, and we see a CT scan, and we calculate the space that we have, and then we'll see a 3 millimeter yes or no, and we'll get into that now. If we wanted to do grafting, it's possible. I can tell you from my perspective, even as a specialist, it's hard to do. I would probably prefer to do a free gingival graft and eliminate the frenum and get some good tissue in there. So it's not going to be an issue later, because don't forget, these teeth, the central and the other lateral, or the two centrals rather, they can be lost in the future. This one was a weak spot. This one was a root canal tooth, so it broke. Yeah. But the centrals, hey, they got like 50% bone loss.
So if you were going to do a free gingival graft, would you do it after completion of the implant procedure? Or
I would probably do it before. I like to do things before for myself, my own preference, my peace of mind, more predictable, less question marks. So if we look at this case, let's say in about 6 weeks, clinical photo, CT scan at our disposal, meaning we can see what the site looks like. If the case needs a free gingival graft, probably do it before, let it heal for 6 weeks, then go in with.
So 6 weeks of
healing. Sorry?
6 weeks of healing is enough.
Well, you didn't graft. I mean, I think you said 6 healing. You said early placement. You mentioned Danny Boozer.
No, I mean, if we were going to do a free gingival graft, 6 weeks is enough to go back and then do a flap again after that free gingival graft?
Yeah, because it's a split thickness flap. You're not detaching the periosteum from the site.
Yeah.
You're not disturbing the bone healing, at least technically. So, and I can tell you, probably, if this is a good implant case, I would, unless it's a big concern for the patient, I would probably not graft the site, but if he needs more grafting, I would probably use a tunneling procedure, a tunneling with alloderm for multiple sites. Are you in the Masters of Soft Tissue or IBM?
Yeah, I just started it.
Oh, congrats. Welcome. You just joined this week?
Last week, this week, just recently.
Beautiful. Yeah. Congratulations. Great to have you. I'm glad you joined and shared a good case. Hopefully this is helpful to you.
Yes, absolutely.
Excellent. Rashad, anything else I can guide the doctor with?
Once I get the CT scan, I will present it again next month.
Yeah, let's do it. And let's see the challenges. I got so many lower incisor cases, tons, like successful ones, bad ones, complicated ones, replacing 1, 2, 3, 4. And I really got a grasp on the lower incisors, also from a communication point of view. Doesn't mean I know everything, but I got a grasp on the particular challenges in these types of situations from a bone perspective and soft tissue. So I feel like that's going to be beneficial to you.